All right, I have a minute after, so we should go ahead and get going. So it is really a great pleasure and privilege to kick off the second annual Diversity, Equity, and Inclusion Lectureship. This lectureship, obviously in its second year, was established under Dr. Kia Washington's leadership of the DEI committee. And the purpose of the lectureship is to recognize the achievements of individuals from diverse backgrounds that are traditionally underrepresented in surgery. And this morning, we have the great pleasure of bringing Dr. Velma Scantlebury, who really is a pioneer in transplant surgery, and for many reasons, and literally has changed the face of American surgery. And with that, I'm going to turn it over to Dr. Washington for an introduction.
Thank you, Dr. Schulich. It is my great pleasure to introduce Dr. Velma Scantlebury. She is the first African-American woman transplant surgeon in the United States. She has received numerous awards, such as the Gift of Life Award from the National Kidney Foundation, Top Doctors Award, Philadelphia Magazine. She's recently honored by the Delaware Historical Society as the first Black female to receive the Delaware Historical Award. She has published many peer-reviewed papers and is a recent author of Beyond Every Wall, Becoming the First Black Female Transplant Surgeon. Just a little background on her. She completed her general surgery residency at Harlem Hospital Center in New York City. Dr. Scantlebury completed her multi-organ transplantation fellowship training under Dr. Thomas Starzl at the University of Pittsburgh Medical Center in 2002, and was recruited by the University of South Alabama Medical Center. There, she rose through the ranks to full professor of surgery, and she was the director of the USA's Gulf Coast Regional Transplant Center. In 2008, she moved to Delaware to join Christiana Care's kidney transplant program. After retiring in 2020, Dr. Scantlebury is currently a professor of surgery at Texas Christian University. Dr. Scantlebury is a fellow of the American College of Surgeons. She's a member of the Society of Black Academic Surgeons, and she is a board member of the National Minority Organ and Transplant and Tissue Transplant Educational Program. She also currently serves as a member of the Boldly Against Racism Task Force of the American Society of Transplantation Surgery and the Health Equity Coalition of the American Kidney Fund. So thank you very much, Dr. Scantlebury, for joining us today. We are honored to have you.
Thank you so much, Dr. Washington and Dr. Schulich, for giving me that introduction. I am honored to be here and to have the privilege of being the second speaker for the Diversity, Equity, and Inclusion Committee of the Department of Surgery. It is a delight for me to be here and to give this presentation virtually, even though we know that the pandemic surge seems to be decreasing. And just about now, I feel like I need another booster, as it's been almost 5 months and we're learning that our boosters are not effective after that time. So anyway, today my topic is entitled, Do You See Me? And for me, this is important for us to think about our own perceptions, how they're brought about, and the role they play in our day-to-day encounters and our own biases. This is what we call the surgeon's dilemma, a test of the unconscious. And some of you may, well, first, sorry, my financial disclosures, I do have to disclose that I do work as a consultant for CareDx and as a transplant consultant, and there's no affiliation with this presentation. The surgeon's dilemma. Many of you have probably aware of the answer, but here's a challenge for you. A father and a son are involved in a horrific accident, and the man dies at the scene. But when the child arrives at the hospital and was rushed into the operating theater, The surgeon pulled away and said, "I can't operate on this boy. He's my son. How can this be?" And I present this because for many of my colleagues, even my husband, he didn't come up with the answer. Don't worry if you're not alone. It seems like less than half of those who try to solve this dilemma struggle with the point that they're thinking, how could the surgeon not operate? And so the point of this riddle is that to really unearth our own biases and show that we have biases that may not necessarily be reflected in our own behavior. And that's the sneaky nature of unconscious bias. Not aware that we have them, and it makes it harder to identify such biases and to do something about them. But if we're motivated as individuals to address our own biases, we can do something, definitely do something about them. And so, as you heard a little bit of my background, yes, I was actually born in the island of Barbados in the Caribbean. I was given a lecture in Wisconsin, and I said I was from Barbados, and person said, "Oh, you're from Barbados, Wisconsin." No, I'm from Barbados in the Caribbean. So I don't know, didn't realize there's a city in Wisconsin that's named or some named Barbados. But my family immigrated to Brooklyn, New York, and I said unwillingly, because at that time I really wasn't relishing the thought of coming from my sunny island to Brooklyn, New York. And so completing medical school and becoming the first of my family to finish college was a very proud moment for my family. They had always instilled in us that the sky was the limit. My mother came to this country as leaving her family behind to primarily provide educational opportunities for all of us. I completed my general surgery at Harlem Hospital in New York City. And this is where, as most of you may be aware, that physicians of color predominate on the medical staff. Moving to Pittsburgh was a different culture altogether. The surgical department had no women on staff, and there was only one African-American trauma surgeon at the time. As you heard in the last year in Bob Higgins' lecture, there were two African-American residents who came on board the year before I got there. And so that was a first for University of Pittsburgh. Our surgery, at the time, the transplant department was one of the busiest. And so Dr. Starza had actually recruited 10 fellows that year, up from 3 the previous year. And I was one of those physicians. I was the only physician of color, but I was one of 3 women at the time. And surgery was really a melting pot of nations from all over the world, as many surgeons from different countries came to University of Pittsburgh to learn the technique of liver transplantation under Dr. Starza, who we consider the father of liver transplantation. But if you were a Caucasian male, certainly you were the expected norm to many patients. And for patients especially, I was not what they expected. I did not fit the profession of surgery. I wasn't like your typical surgeon. And so often I heard about, from the patient, so when is the real doctor going to come? And many of you probably still, as underrepresented minorities, may still face that. And so what exactly is the cultural norm of your typical surgeon? Historically, unfortunately, medical institutions did not have women or members of the minority group in positions of leadership or authority. And this resulted in professional norms that were largely centered around the white male identity and the broader cultural norms associated with whiteness. And so this was something that was different for me because what I heard arose out of their own expectations of what society led them to believe was the acceptable norm. And so the term professionalism often is used to describe a broad set of behaviors that may be based on your own behavior, how you expect that person to dress, language, and even hierarchies that were deemed appropriate in medicine. And so in this concept of the profession of surgery, you don't really see anything in there that should reflect race or sex. And so this concept of professionalism did not include diverse groups and therefore can be non-inclusive. And our cultures may cause us to perceive differently in certain groups and as what they wear and how they present themselves as being unprofessional. And I will touch on this later in the presentation. Looking back on the US suffrage woman movement, which was centered around the inequity of men and women at the time, led to a shift in gender relations and eventually impacted the role of women and the economic structure that existed. Women no longer wanted to be viewed as property or subjected to the assigned roles from men. They wanted not only to vote, but they wanted to own property. Such systems of oppression as an individual or institution, or even at a society level, can have a lasting effect on people that becomes deeply rooted in our own culture. So in essence, they were desiring other identities established in their own social presence. Whether we are aware of it or not, we are all assigned multiple social identities. And within each category, there's a hierarchy, a social status with dominant and non-dominant groups. And as with race and gender, dominant members can often view other members they deem as normal, or they can also limit the opportunity to members that fall into other categories. So there's almost, when we look at this chart, an endless number of ways that society can categorize people over time. And it's not just race or physical disability. It can be your socioeconomic status. It can be your religious background, your sexual identity. And these can oftentimes cause people to be categorized. And society identifies a person based on the social group and their memberships. And so we all make emotional investments in our own group memberships and to build self-esteem. I feel better when I'm in a group of people who look like me or who share my same identity. And I may be more at ease when I'm around my family because they share my values. And so we choose to embrace the social identity. If we choose not to embrace the social identity of others, then we fail to make them feel welcome. We fail to make them supported or even respected. And this can result in an uncomfortable situation, especially for those who find themselves alienated. Now, social identity can be at the root of how we all experience as individuals in the world. And unfortunately, stereotype is just one of those implicit bias identity operations that cause us to see people differently. And so when our environment is inclusive, it makes us feel safe. And one type of threat to our identity is stereotyping. And so, however, members of our marginalized population express greater infringement on the professional boundaries during interactions at work or learning environments. And we know that these infringements can range from microaggressions to blatant racism to sexism. And whether subtle or aggressive, these can often disproportionately affect women, those of racial and ethnic minority groups. And even though implicit biases can be positive or negative, they affect us in either way. Certainly if you, as most someone from an Asian background, you would often get the remark, "Oh, you must be good in math." And when someone takes offense to that, it's often viewed, well, I'm trying to pay you a compliment. Well, that's not exactly a compliment, as much as my nephew who's 6'5", and they're always expecting him to play basketball. And so even though it's well-intended, it is not appropriate. And so when we get to really look at or understanding unconscious bias or racial bias as we look at it, or implicit bias, these attitudes and beliefs reflected on another person, while you may be unaware of them, they're really influenced by your own culture, your own stereotypes, and how you view others and your own values. And so when we recruit medical students or residents, we want to make sure that our own implicit biases are not reflected in how we interact with these students. And oftentimes students can feel like, and residents, that they're under a microscope, especially when it comes to recruitment and retaining future health professionals and increasing the workforce, the diversity workforce. And this can hamper our efforts towards making that workforce larger. We often judge others based on what we consider the norm. And as a Black surgeon, would it be unprofessional for me to wear my hair in braids or in an afro? Because that's not viewed as the norm. And therefore, while it may be accepted in my culture, others may see that as being unprofessional. Dr. Dominique Alexis, in her article, looking at, the assessment of perceptions of professionalism among faculty, trainees, and staff, really examined the context of how professionalism is operated and perceived in diverse healthcare workflows. And what she found, that there was a greater infringement on the professional boundaries, as well as increased scrutiny on many of the professionals. And this created a tension between inclusion versus assimilation. And this can impact not only how we are perceived, but how we're treated and engaged by others on a regular basis. And so some of the representative quotes that she outlined in her article, these were a few of them. I met with my senior male faculty, and I was pregnant at the time. But however, he spent a fair amount of time talking to me about my plans to breastfeed, how it would impact my life. And it may seem things like I maybe have this feeling of walking around with a child on my breast all the time. And so she felt that there was certainly made her feel uncomfortable. And that person may not realize that they were infringing on professional boundaries. Residents of color get more criticized for things that the majority do not, even if they do the same things. And so others, I think about the conversation about other students who don't fit in, and we're describing how different they are. And so these are just examples of infringement, pressure to conform, and even being at increased scrutiny. So identity plays a large part in how we move through the world, and therefore our people and systems treat us, and the opportunities that are available to us often can be due to these biases. And so each of us have these social identities as described previously. And however, we do not want these social biases or implicit biases to be reflected in our policies and our practices that begin to benefit certain people and put limitations on others. So how we treat others on a professional level matters. How you see a new medical student who is Latinx, or an LBGT surgeon or Ethiopian consultant, to view them not as different, but to embrace their differences. And so in this slide, I have, what do you see when you look at me? And I want to challenge you to, when you look at your other colleagues, to really think about, how are you viewing them? How do you see them beyond your own lens? And these are just some of the microaggressions that are documented in the gallery that was published by Georgetown University School of Medicine. And ask yourself, could you be the person making these comments? Oftentimes, I'm sure many of those who are underrepresented, even as students, are often told that even surgery may not be an option for them because it's difficult. Or even for older students, are you a little old to be in medical school? Are you sure you want to be a surgeon? What about your family? Those kind of things. And these microaggressions can really have an effect on all of us. So there are consequences to these, and many respondents perceive pressure to conform to the dominant norms of their workforce. And this can affect us in many ways. Oftentimes, students feel marginalized, residents feel excluded, and often feel like they're interlopers. They're there, but they're not really belonging. And the negativity can impact our own self-esteem and self-doubt and create a certain amount of stress for those who are subjected to these behaviors. And so for someone who feels a strong sense of push towards uniformity, or they may feel that that is that may come at the expense of their own individuality, and the energy that puts forth into trying to fit in can really be stressful. However, students often report, and I can only say that when you encounter positive experiences with others who fit your racial and ethnic group, these experiences are appreciated. And when patients appreciate your interactions with them, you walk away feeling valued. You will feeling like your presence mattered to that person. And that's how we really want to feel on a regular basis. Our bias is also reflected in how we see patients. What do you see when you look at them? The same issue of implicit bias is not only exists in a peer-to-peer interactions, but also how we encounter our patients, our patient care. And this is reflected in the outcomes that we see in the following slide. This study from the Institute of Medicine Committee on Understanding and Eliminating Racial and Ethnic Disparities in Healthcare was published in 2003. And it looked at the ability to assess evidence regarding racial and ethnic differences in healthcare. And they conducted a series of literature searches via PubMed and Medline databases. And really, what they found was that evidence existed, with a few exceptions across the board. There was remarkable consistency. And these disparities were oftentimes maybe associated with socioeconomic differences, but tend to be diminished when these factors were controlled. And even for me within a transplant, even though this article is from 2000, we know that disparities have existed in transplantation and have been discussed in many articles for many years. And unfortunately, while there are systems in place to try to improve or eliminate some of these disparities, many of them are subjective. And as we see in this article, that when we look at those patients who were rated appropriate candidates for transplantation, 9% versus 20% when you look at African Americans versus Caucasian. And so this becomes an issue and has been an ongoing issue within transplantation. And disparities in transplantation, while, as I said, have improved, there are still barriers. And the question is, are these systemic barriers, are they patient-related, or are they physically related for patients? And we still know that within transplantation, there are modifiable factors and those that are not modifiable. But unfortunately, we still find that referral to listing disparities still exists. Certainly, the biggest issue we're seeing is that live-in kidney donation and preemptive transplantation, which relates to education and what patients and where they enter the medical care system. If they enter late, they're oftentimes, because of unfortunately, a healthcare system, they will not have that advantage of being able to have a preemptive transplantation. So understanding these barriers will allow more education from transplant facilities and from doctors to really intervene to figure out how can we optimize the transplant evaluation process and improve patient outcomes. And so these factors, while are seen as barriers, both systemic, social, and racial, contribute not just to the general health, and to many subspecialties in other areas. And these inequities remain part of the important and difficult issue to tackle due to the uncomfortable nature of discussing these things. And we know that to address racial and ethnic disparities, while it's difficult, we have to take our blinders off and we have to begin to examine our own attitudes and how we think about this. In our next slide, we see that this review examines the evidence of healthcare professionals in a review system. And basically, when they look at all the articles, they found that all studies investigated found a significant relationship between level of implicit bias and lower quality of care delivered to patients. And we know that this is ongoing. A recent development of a recent story of a British woman who had 8 miscarriages was just in the news last week or a few days ago. And she felt that even though she had issues, medical problems, that she wasn't being heard. She had many questions, many answers, but felt ignored and felt like she didn't matter. And we know that even within this subsector of medicine within OBGYN, that Black women are at 40% higher risk of pregnancy loss compared to white women. And so it is important that we listen to our patients, we understand where they're coming from, and that we hear their complaints and their issues and respond in an appropriate manner. The concept of cultural competence was discussed by the American College of Surgeons in this article back in 2012. And understanding cultural competency is understanding what is at the core of our environment that influence our own behavior, our beliefs, and our health decisions. It's about understanding the specific culture, the language, and the social and economic aspects of that particular group and being sensitive. And without that, we really cannot deliver our best healthcare. But we know that embracing cultural diversity means appreciating the differences in individuals from various backgrounds, and being sensitive is to respect and value those cultural differences. But typically, cultural competency training focuses on how to treat patients according to their cultural needs. And so what the Harvard Medical School course emphasizes is that self-awareness emphasizes self-awareness as a way to identify and overcome cultural conditioning. And so they looked at cultural humility. And so it's a process not only of understanding, but self-reflection, or having that inner self-critique, whereby the individual not only learns about another culture, but examines how his or her own beliefs affects that cultural identity, and having a humble and respectful attitude towards others of different cultures. It really pushes you to challenge your own biases, because we can't possibly know everything, and we shouldn't pretend to know everything, but we need to approach this learning as a lifelong goal. And part of cultural humility is holding our institutions accountable. Do they have the necessary tools in place to accommodate the needs of the patients of different cultures? And one example of this is that if you a physician and you're moving to New Mexico and you know that you're going to have a lot of Hispanic patients, you may go ahead and learn about the culture, and so you can understand better and their practices. But then you see a patient and you learn that you, in your mind, you're assuming that because there's a high incidence, that there's most of them may tend to be say Catholic, you decide to call a priest into this patient, and you didn't ask that patient. But so now the patient turned out to be, even though he's Latinx, he's also Jewish, but you make that assumption. And so even though you learn about that patient and you put yourself in a position to be culturally sensitive, you also have to make sure that you have a respectable attitude towards that patient. And ask them the question, are you Catholic, or what is your religious? So you may not know everything about that patient. So you want to embrace the differences and be culturally and be willing to accept those differences. When I was in Pittsburgh, one of the groups that we encountered was this Hasidic Jews, and they lived very much within our neighborhood. And many of us were initially offended when they refused to shake our hands, but it wasn't until we learned and understand that that was part of their culture, and therefore, rather than having a negative response to that, we need to be culturally sensitive and be humble and be accepting of what they see as within their own cultural norms. And so in this article, Reducing Implicit Bias by the Association of Women Surgeons, they recommended several things, and this was from 2019. And so here, everyone, our different groups have different recommendations for what we can do about this. And this task force recommended various recommendations: provide an educational opportunity to the staff, to the staff. While we provide that education opportunity, we want to make sure that the staff is taking advantage of it. Do they really understand what they're being presented with? Are they embracing that? Most of us are not aware of our own biases, and some of us accept it, and some of us don't want to be involved. And so for many institutions, they give the opportunity for the residents and the staff to take the IAT test, but it's controversial, and some people find it useful of challenging your own biases. But the biggest hurdle is not only to commit to a cultural change, but to have that desire to understand your own unconscious beliefs and have the willingness and desire to change. And these are all excellent recommendations when it comes to conducting an introspective department assessment, implemented processes for hiring and promotion, and certainly encouraging mentorship and sponsorship. And I think most importantly, empowering the individuals to be able to speak up, or to be able to know where they can find a safe space to be able to voice their concerns. And so we all know the benefits of healthcare diversity. It not only improves communication and trust. Patients like to see that and to know that those who are taking care of them, that they have a certain level of trust and understanding in the caretakers. And certainly it increases engagement and builds creativity and fosters a better environment for our staff. We know that there are current gaps in healthcare, and part of doing this and having this diversity work that's being done by Dr. Washington and her team is that we want to close the gap. We want to be able to increase the amount of physicians of color and underrepresented physicians within healthcare. And we know that currently 5% of all physicians identify as Black or African American, although we make up 13% of the population. And about 6% identify as Hispanic, despite there being nearly 20% of the population. And while a majority of our healthcare workers are female, just less than 25% may be reflected of non-white individuals. So why is this important? Because we need to make sure that we are not having tremendous dismissal of our medical students and our residents, we're not losing them in the pipeline because of the biases that are put forth. And so while this data is reflective of 2015 to 2016, it is important because many underrepresented minority residents feel the pressure to conform and are more scrutinized. And not to say that there are not causes for appropriate dismissal, but practices need to be uniform across the spectrum. And if we look at the African Americans in the green bars, we find that certainly for surgery, the dismissal rate far exceeds those for other ethnic groups. And so we have to understand that when you look at most training programs, if we make up 5% of African-American surgeons, and as men 3% or women 2% or 2.9, certainly you're talking about 1 to 2 residents per program. And if the dismissal rate is this high, we're losing many through the pipeline. And this is important to understand, as this data is borne out in this study examining the intersectionality and pipeline for Black academic surgeons. And while this may be hard to see, there's a trend in general surgery residency applications that show that when we examine the data, that little has changed when you look at the top line here being white, the middle line being Asian, then Black and Hispanic, and on your far left, it's women, and this is men. We find that when we look over the years, and this is going all the way back from 2005 to 2020, you find that the pipeline, when we look as far as males, there has been really little change over 13 years for Black males. And while for white, the numbers have decreased, and overall, it accounts for the rise of Hispanic women and some rise up for Black females. But as far as for Black males, it has remained pretty much underrepresented and changed over the years. This, even though this was recent study, when you go back to and represents over 13 years, looking at this study in the New England Journal of Medicine, diversity of the National Medical Student Body, again, we find that certainly for women and men, this goes back to 1978. The changes that we see here are minimal. You certainly have a rise of Black women and Hispanic women, but not for Black men. And Black men in 1978 accounted for 3% of the national medical student body, but by 2019, this cognitive figure was down to 2.9. So in the past 4 decades, despite major strides being made in the representation of women in the national medical student body, the proportion of enrollees from racial and ethnic groups that are still remain underrepresented in medicine. And why is this important? Because diversity matters. And so the two major goals required to address underrepresented minorities in academic medicine is to enhance the number of academic physicians and biomedical scientists. First, we want to increase the pool of those who pursue health-related sciences by attracting graduates at an undergraduate or even at a high school level, because that is important. Secondly, we want to develop strategies to retain our junior trainees and our faculty members, and even to encourage more medical students to pursue the areas that are certainly underrepresented across the board. Dr. Joan Reed, in her address to the Clinical Congress in 2018, talked about the culture of diversity, the value of diversity, and the importance of a diverse and inclusive workforce, allowing everyone to be treated with dignity and respect, and where our talents and our skills are valued regardless of what group we are from. And so we need to examine our own values, how we view others, as a diverse surgical workforce that can lead to more inclusive, more patient-centered care. And we all are aware that a diverse workforce is more likely to consider the problems from all angles, and oftentimes can come up with solutions that better reflect the needs and the concerns of patients. So 5 strategies for addressing disparities from the Massachusetts General Hospital-Based Disparities Leadership Program report are quite similar to those that have been presented before. Know who is involved. as far as organizational leadership and from the top, and begin to shape the culture of your organization so that everyone feels valued. And it's important for everyone to really have a role or be invested in making this happen, having those positive outcomes. Go back to that. And we want to engage everyone and harness so that we can have a network that's collaborative, leading to better healthcare and better outcomes, both professionally and across the board. And so this image is from the New York Times by Tim Cook, and he talks about how our brain processes algorithms and how these algorithms have a built-in racial bias. And so we want to examine how we see our patients, how we see our peers, how we see others who don't look like us. And we want to be able to have those algorithms that we know oftentimes that we confront even within our systemic system right now, that we know there are algorithms that are biased when it comes to racial inequities, and we're working to eliminate those algorithms. And so personally and individually, we need to think about how we're processing what we see and do it within a humble and respectable manner so that we can begin to eliminate our own negative biases. We all have biases, but how do we process them? How do we think about who we see, what we see, and embrace the individuality of those that we work with and encounter? So I want to say thank you so much for having me deliver this second DEI presentation. Dr. Bob Higgins was, I mentioned, was a resident when I was at Pittsburgh as a fellow. And so I am delighted and honored to see that he has risen to the ranks of now being CEO at Mass General. And I want to say happy Valentine's Day to everyone. And also Heart Month. Stay healthy. I know you guys had a lot of Super Bowl stuff yesterday, but now you're going to put on a new leaf and stay on a healthy diet. So happy Valentine's Day. Thank you so much.
Dr. Scantlebury, let me be the first, and then I'll turn it over to Dr. Washington and then over for questions. But thank you for that wonderful talk. And, you know, the events over the past, I think, couple of years have really brought things more to the forefront. But you know, in this nation, this has been going on for 200 years, 250 years, and on this continent, it's been going on for 500 years. And you know, you know, this has been a journey really for me, and I have evolved during my career. You know, I look at where I was as a medical student and as a resident, and I look at where I was as a junior faculty member and now as a leader. And this has been a slow process for me, but I would say personally, I've become much more aware. I know I'm not totally educated, nor can I know everything about all the issues. But over the last couple of years, I have learned so much, and it's through lectureships like this, and it's through leadership that Dr. Washington and the DEI committee provides. You know, our goal is to get to perfection, but the only way to get there is to just start walking, start talking about the issues, and most importantly, I think for me, is to really learn about the issues. And over the past couple of years, you know, I've realized I've been wrong in many different areas. And, you know, the classic example that's freshest in my mind is in our residency application program. We've gone to this holistic review where we don't, you know, place at the highest level, you know, your exact board score, number of publications, you know, which school, but we look at individuals holistically and what they can contribute to the residency and the training program. And having been through this process, I have to say that we have had the most diverse applicant pool that I have ever seen anywhere. And they have been spectacular applicants, and I would be very proud to be working with any of them and to be training them. And so, it's just steps like this. And, I'm getting to be an old surgeon. What took me so long, to learn about these things, but having lectures like this are so important, and we all have a lot to learn. And I think we need to keep an open mind and to maybe challenge some of the more traditional thinkings that we have had. And let me just congratulate you again, and thank you so much for coming virtually and presenting this. Thank you.
Thank you so much. It's so very important to really be self-reflective in terms of what we think consider are important aspects for what criteria for being inclusive or being just for admission. And I know I sat on the admissions committee for a review for residencies from medical students, and so often, if the medical student came from a school that wasn't recognized, they were dismissed. Unless it was, I have to know, well, I never heard of this medical school, then they get a lower score. And that's not appropriate. And so I appreciate your ability to see beyond this and to look at students on a holistic level. And that's so very important. And it's also important to have representation on these committees who can often speak up on behalf of those who may be marginalized.
Thank you. Thank you so much, Dr. Scantlebury, for your presentation and for continuing to educate us on these really important issues. And I can only imagine some of the experiences you've had in your illustrious career. And we are just thankful to have you here to really gain more knowledge from you. We do have some questions from the audience. I'm going to start with one from Dr. Cleveland. What recommendations do you have for trainees, staff, and peers to help mitigate health inequities on an individual and systemic level? And how do we gain knowledge about this topic?
Yeah, I don't have all the answers, but I think recognizing that you want to learn more is a big step, even on the individual levels. And I know there's a lot of controversy around the IAT test when it comes to racism, but I challenge everyone to just do it. Just try it. I don't know if you have the website for that, where you can actually go in, and many people are really moved or concerned that they don't believe the findings, but we don't understand our own biases when it comes to being aware of them. So learn as much as you can. There are quite a few programs that may be accessible. It's also important to have a safe place for you to discuss your concerns and to have that being able to share things that you feel may be inappropriate, or even how to respond. And I think when trainees or staff or even have an opportunity to come together, you realize that perhaps you all have similar concerns, or that maybe there are solutions that you can share amongst the group as a whole. So certainly understanding and seeking more information and opportunities to learn how to eliminate or how to confront your biases is important.
Thank you very much. We have another question from Ms. Tracy McDermott. Thank you. She said, thank you for a terrific presentation. What changes have you noticed throughout your career in medicine that have moved the needle for people of color and marginalized groups that have been positive? And what is the best approach to continue fostering these positive changes?
I think the biggest change that we have seen is the ability to move it to the forefront, to talk about it. It's always existed. But now we're not necessarily viewed as being sensitive or taking offense to things that are wrong. We now have a voice, we have a platform, we have an ability to speak up. And we know that some of the biases and even discrimination and microaggressions that were accepted in the past are now being identified. And it allows for us to have a voice. It allows for you to speak up. Certainly as a resident or a medical student, you may be concerned about the repercussions of confronting things that you see or happen to you, but I encourage you to bring those to your upper level or to someone in authority so that they can begin to identify what these issues are and also to do something about them. And I think what is the best approach to continue fostering positive changes is that we have to have buy-in at our levels. You have to have those members of the staff who really see it as important and can begin to do something about the issues you are facing either as a resident or a young staff member. When someone is dismissed, then they feel like you really are not advocating for us. And we need to have allies in all aspects, not just the underrepresented minority staff, but also within the majority. Allies are important because the problem doesn't necessarily, we are not the only person in the issue. It involves all persons. And those of the majority need to recognize that and to speak up and to advocate for those who are being marginalized.
I have a quick question about microaggressions. I think, particularly people of color and women have experienced, and people from other marginalized groups have experienced microaggressions sometimes on a regular basis. But they can be tricky when you're explaining it to somebody that's never experienced a microaggression. They don't see it the way that you see it because they've never experienced it. What advice do you have to make people that do not experience those types of things on a regular basis, to make them understand the impact that they have, and that they exist, and that they are real?
One of the things I learned in some of the courses I've taken have been to ask why. Sometimes patients or someone would say to me, "Oh, why do you think that is? Or why would you say that?" For example, from the Caribbean, I may have an accent, and so persons may say, which is not appropriate, "Oh, you speak great English for a Black person." What exactly does that mean? And so I said, "Why would you say that?" Then they have to think about it. Well, why did you say it? Did you think that Black people don't speak good English? Or did you think I didn't speak English? And now they may cause them to wonder, why did I say that in the first place? Because now they can't explain it without being embarrassed. And so often, rather than being negative or taking an offense, the question why is, what led you to that opinion? Or what led you to say that? Because it then sparks internally, it turns their mindset and they may not know what to say. The same thing of when someone would say to me, well, like oftentimes, so I'm rounding or I'm with a group of other white team members and I walk into the room and so they address the white male as being the leader of the group. And they constantly, I say something, they talk to that person. It's often we all encounter that. At what point do you interrupt? Sometimes I may have to show my name tag and say, "I'm Dr. Scantlebury. I'm in charge here, and I would respect that you address your concerns or your questions to me." Just in terms of being polite. And so that's just a few examples.
Thank you. Another question from Jason Owens. What would you tell your younger self about some of the challenges you've faced in your career? And would you change anything?
What would I tell my younger self? Be bolder. I think I can honestly say that for many of us as underrepresented minorities, we are the only one in the room. And oftentimes, we feel like an imposter. We don't belong there. And so we withhold. We don't speak up. We are intimidated, or oftentimes when we speak up, we are ignored. And so I initially felt, and certainly was in those situations. Now for my younger self, I want, with the ability to now be able, and then, as you get older, you now are less tolerant of things that you tolerate when you were younger. But I think I would tell my younger self that have more self-esteem, trust and believe that you belong there, and accept that challenge, and be heard, let your voice be heard, and be seen. And so for me, I was very introverted, and that would be, I would like, and I encourage medical students and residents is also make sure that you're seen, make sure you're heard, and you're not left behind.
Thank you. We have one last question from Jonathan Radin. It seems rather apparent from the events of recent years and the assault on voting rights that we are more than capable of taking steps backwards as a society. How do we shift the mindset of this important work to accept the idea that this is not something we ever get to say we are done with, or that we're successful, and that it is a dynamic process that we can never stop striving for?
Absolutely. We have to keep the needle moving forward, and we cannot allow it to move back. And that becomes important for us, for this generation, for the next generation. We need to be advocating for our own rights. We have to be advocating for what we believe in and not go backwards. So we each cannot sit back blindly without being involved. And that requires each and every one of us taking a stand and doing what it takes to make sure that the needle moves forward. And we do have that potential for going backwards, but we have to make sure that we do not. And that is really an individual responsibility for all of us.
I think a great leader, I'm paraphrasing, but if you're silent, you're complicit.
Absolutely. Yep.
Martin,
you don't have to be a rebel. You just have to make sure that you're advocating and be seen and heard and be in the masses to move the needle in the right direction.
Thank you so much. Those are great words to end on. Again, we really, really appreciate you coming for our second annual DEI lectureship. And it was so amazing to hear your lecture and also your comments to our questions. We are greatly appreciative of your wisdom. So thank you very much.
Thank you. It's my honor and privilege to do this, and I hope that the majority of the audience found it informative and useful. There's always that opportunity, that unfortunate side where some may be offended, but fortunately, we want to be able to have that humility and respect of our colleagues and our patients, and it's up to us as individuals to really look inside us and see how we're viewing others. So thank you.
Thank you.
Thank you.